top of the hour, and this is Ethics Grand Rounds. I am Julie Swaney, one of the co-chairs of the Ethics Committee at University of Colorado Hospital, and work with a committee of people putting on Ethics Grand Rounds. Want to welcome all of you to this hour, and also especially want to welcome our presenter today, Dr. Anuj Mehta. He is known to some of you and has generously offered to present today on an ongoing issue that was punctuated by COVID, which are ethical issues in staffing. It's not over, and it predated COVID. It has, and the pandemic, it is continuing. And so Dr. Mehta has been working on this in a variety of settings. Dr. Mehta is an assistant professor of medicine at the University of Colorado School of Medicine and practices pulmonary and critical care at Denver Health and at National Jewish Health. So thank you, Dr. Mehta. And for those present, also, if you would put your questions or your comments in the chat, we will have an opportunity to get to those at the end of Dr. Mehta's talk. So again, welcome, Dr. Mehta, and thank you very much.
Thanks so much, Julie, for the kind introduction. I'm going to go ahead and share my slides. All right, perfect. So as Julie mentioned, my talk is entitled Ethical Issues in Staffing. It's not over. And I want to offer some disclosures to start off with. I have no relevant financial conflicts of interest. I do receive funding from the NIH currently for unrelated research to today's topic, but I've previously received NIH funding related to provider burnout, which can be related to staffing, as I'll get into. And then I also served on the Governor's Medical Advisory Group, dedicated to crisis standards of care for healthcare staffing, and helped develop the state's documents. The learning objectives for this talk today are: we will review staffing issues prior to the pandemic. We will review the interplay between healthcare staffing and crisis standards of care. And we will also discuss how staffing shortages can lead to, downstream and upstream ethical conundrums. And then finally, we'll discuss potential solutions to staffing. I want to start off by fully recognizing that I might not be the best person to give this talk. I'm a physician. I spent a lot of time doing research, and in the last 2 years, I've spent a lot of time, extra time in the ICU, and also doing work for the state. But staffing has, while it's affected physicians, the impact pales in consideration for staffing for other provider types, specifically nurses, respiratory therapists, medical assistants, and home health aides, as well as all other types of healthcare providers. So I fully want to recognize that I'm not the most negatively affected by the staffing issues, nor do I face all of the ethical conundrums, but maybe I can give a brief introduction here, and then I hopefully we'll have time for commentary at the end, and then people from other fields can also offer their views. I think before I get into those 4 objectives, one of the key questions really is, why are we talking about ethics and staffing? Staffing seems like an operational issue amongst hospitals. It does impact how we care for patients, but it seems like when you think about it, it's how many people do we hire, how many nurses do we have per patient, how many respiratory therapists do we have per patient, and more importantly, how much can a hospital afford, and what's an appropriate level of staffing? On its surface, it is very operational, and I would argue that prior to the pandemic, it was viewed as an operational problem without a lot of ethical conundrums. But I think that if we reflect on what we've learned over the last couple of years, and then use that lens to view the past staffing crisis that existed even prior to COVID, we realize that really there are deep ethical questions that are intricately linked to staffing. And specifically around this idea that competing interests always inevitably leads to ethical challenges. And there are inherent competing interests sometimes between these 3 core groups within that constitute the healthcare system, namely hospital staff and patients. And we'll go through that. So to start off, I would like to review staffing issues prior to the pandemic. We all recognize that staffing has reached even more crisis levels, and it's a odd way we phrase it, but it's actually apt to say more crisis in the last 2 years, because even before the pandemic, we really were at a critical juncture in terms of how we were staffing healthcare. There was a great deal of regional variation, but even within large metro areas, there were certain limitations. So where were we before the pandemic? I'm going to show a few different research studies that were conducted before the pandemic. This is a study that was in JAMA in 2000 that looked at the implications of an aging registered nurse workforce. And I can say this from my experience in the ICU. One of the things I love about the ICU in every place I've worked is a multidisciplinary team approach. Namely, I get to work with amazing nurses, amazing respiratory therapists, and the senior people that have been in the ICU for 10, 15, 20 years, I mean, they have more critical care experience than me, and I learned so much from them. And I learned a lot from the newer nurses as well, newer respiratory therapists, but that experience has been critical to my education. And so this study looked and recognized that a big cohort of nurses, especially at the turn of the century, were aging out of the profession at higher rates than younger individuals were entering the profession. It's interesting that as I read this, I think back, this wasn't that long ago. This was 22 years ago. But if we look at the language chosen, we realize that even then it was dated. The primary factor that has led to the aging of RN workforce appears to be the decline in younger women. We know that both men and women enter the nursing field. And we've seen more men entering the field of late. But really, there are fewer younger people entering the field. This study from Health Affairs in 2015 really looked at the nurse shortage to improve the quality of patient care, but cited the same issue around aging workforces, difficult work environments, and also the shortages in the number of spots in nursing education spots, both for nurses, respiratory therapists, but also declining spots in med schools. And that was leading to a difficulty in training new people as they enter the field. So there was a shortage in the training pipe. And that was all impacting the predicted shortage that we were going to see. This study was published in 2021, but really utilized data pre-pandemic, and it looked at the chronic hospital nurse understaffing meeting COVID-19. And I think the key takeaway here is not necessarily what COVID did, but that this was a snapshot of what was in existence before COVID, highlighting that hospital nurses were burnt out and they, in large numbers, worked in understaffed settings. And those laid out risks to the public health, especially as COVID entered the United States. I think this is a really great article from 2011 from New England Journal of Medicine that really looked at nurse staffing and inpatient hospital mortality, which again, if we think about the trifecta of the healthcare system, hospitals, staff, and patients, a lot of times we want to associate the issues with hospitals and staff to the core outcomes of patient outcomes. And in this retrospective study, they found that when nurses were working at target levels below what they felt was a safe staffing level, there was increase in patient mortality. And so the staffing issues directly impacted patient health. And this is where we start addressing a lot of the ethical conundrums, because I think some of the core ethical principles that we focus on, at least in healthcare, have to do with patient care, patient quality of care, and patient outcomes. We focused a lot on nurses because I think that's where a big part of our shortage exists, but we can also look that there was an expected shortage of physicians even before the pandemic. So this is using data from 2018 and 2019, and they projected out physician shortages through 2034. And the graph is showing the range, the expected range of shortage. So they predicted that by 2034, we would have a shortage of anywhere from 37,800 physicians to 124,000 physicians. And in the text box, you can actually see that there was a breakdown between primary care physicians and specialty physicians. And I think this is really important to focus on, that there's also a lot of regional variability in where the shortages exist. In some places like New York City, there's an excess of specialists, but there might be a shortage of primary care physicians, and the inverse may be true in other locations. But the take-home point is that even physicians had pre-existing shortages before the pandemic. So what's the state prior to the pandemic? And this is actually mentioning some of my own data on burnout that with a study that I completed in February 2020, which was very apt in terms of getting a good snapshot of burnout prior to the pandemic, but really that there's high burnout across all medical subspecialties and across all provider types, physicians, nurses, respiratory therapists, pharmacists, that shifts in staffing models have led to fewer full-time nurses, leading to more unpaid on-call time, more overtime, and higher patient loads, all of which have been associated with higher levels of burnout, and an increased desire to leave the field, which exacerbates the staffing shortages. And that healthcare, there was a general sense across multiple studies, not just my own, that healthcare staffing systems prioritize profit and increase the corporate environment, and it was perceived to be less patient-centric. So where are we now? The current crisis. And so this is quoting a couple different sources that really, and we've seen a lot of this in mass media, that look at where are we heading. And so 1 out of 5 physicians plan to quit in the next 2 years. I know several of them that are planning on leaving the field. 30 to 40% of nurses plan to quit in the next 2 years. That was an estimate taken about 6 to 8 months ago. It's unclear if, as things from a COVID perspective get better, if those numbers will hold. And that both of the studies that contribute to these numbers highlighted that there was a significant portion of people that they may not leave the field, but they were going to cut down their hours. And they were far less incentivized to provide overtime or cover an extra shift. Turnover is greatly increased, and that there's a greater exodus of older, more experienced staff. And what that's led to is that in places that typically require years of experience, like emergency departments and ICUs, you're seeing far younger staff or new graduates, whereas you wouldn't have seen that before. And that clearly impacts the patient care we could provide when, as a general issue, the level of experience has decreased in some of our most critical units. So I want to review the interplay between healthcare staffing and crisis standards of care on 2 levels, because I think this is where we get to some of the crux of the ethical conundrums. As a reminder, the care continuum that was described by the Institute of Medicine that really looks at the demand for healthcare, and specifically the supply versus the demand. And this is usually been conceived of as in 3 categories: conventional, contingency, and then crisis. So as demand increases, you move from conventional to contingency and then eventually to crisis. There are no clear definitions what constitutes this, and it's actually led to a great deal of debate over the last couple of years of what constitutes the difference between contingency and crisis. But really what this focuses on is that as you increase the demand of healthcare without expanding the supply, you increase the risks to patients. And what I'm highlighting here is the staff. And so in conventional times, we have our usual staffing models, including individuals who might be called in while off duty. So that's what we had before the pandemic. I think I've made a pretty convincing argument that even that wasn't ideal. And that when we move in contingencies, we start seeing longer shifts, different staff configurations, and different supervision. And I think we were actually seeing some of that before the pandemic. And this has definitely been present throughout the pandemic. And that when we enter crisis, that's where we have significant change in nurse and MD ratios, major changes in clinical responsibility. And to a certain degree, that's actually also happened throughout the pandemic. And I'll come back to that in a little bit. So how does staffing interact with crisis standards of care? At the beginning of crisis standards of care, at the beginning of the pandemic, and when we rewrote our crisis standards of care, we were really focused on the shortage of stuff, the shortage of ventilators, the shortage of ICU beds, and the shortage of dialysis. And that was a very easy thing for, I think, both healthcare providers and the mass community to wrap their heads around. Not that it was easy to conceive this idea of where we might have to choose between patients, but it was this idea that, okay, I only have 5 machines and I have 10 patients in need. That idea of that would be a trigger to activate crisis standards of care, conceptually, I think made sense to some people. It gets a little bit different with staffing, but the direct association here is that you may have a lack of staff that can force the closure of hospital beds or ICU beds. And if you actually go to CDPHE's website, their COVID data, dashboard that looks at hospital and ICU utilization over time, they report a percentage. We have this many hospital beds occupied with this many ICU beds occupied. If you actually look at the denominator of that number, you can see that it shifts over time, indicating that we really are at sometimes having to close different hospital beds due to shortages in staff. You may have a lack of staff that forces ventilators to go unused. So if you can't fully staff your ICU, you may have 20 extra ventilators, but you may have nowhere to put them, or you may not have enough nurses or respiratory therapists to provide adequate care to those patients. Or one of the other pain points that we saw was a lack of staff may force people to forego dialysis. If you have 4 dialysis chairs, but 1 nurse, and typically you need maybe 2 or 3 nurses, you may have to shorten dialysis sessions, or you may have to tell somebody that they have to switch to 2 dialysis sessions a week as opposed to 3, or change how you perform inpatient dialysis. In essence, here, even if you have the physical resources, the beds, the ventilators, or the dialysis machines, you may still be required to go into a triage mode because you don't have the staff to actually operate those items. So that's the direct association between staffing and crisis standards of care. And we can all see the ethical issues that exist around being forced to go into triage when you actually have maybe an extra bed or an extra ventilator. There's actually a more subtle association between staffing and crisis standards of care before you get to direct triage. And direct triage implicitly implies that you're going to choose one patient for a resource and maybe not another. And when it comes to ventilators, the individual who may be chosen not to receive a ventilator but receive an alternate care like palliative care, that person's likely going to die. But there's a more subtle association, and it hinges on this definition of contingent care, back to that conventional contingency and crisis. So contingent care is defined as functionally equivalent care to conventional care. But the question comes about, is that really true, especially for prolonged crises? And for most of the pandemic, nurses, respiratory therapists, physicians were asked to care for more patients than they typically would, but it was viewed as functionally equivalent care because people were still receiving the physical resources, namely the bed or the ventilator or dialysis. And we've heard many stories of ICU nurses or ICU respiratory therapists having to care for far greater patients than they typically would. An ICU nurse caring for 4 ventilated patients instead of their usual 2. Well, what does that mean in terms of functionally equivalent care? So this is a study I actually did prior to the pandemic. It was published in 2019. And what we looked at was this idea of whether, at least in the case of mechanical ventilation and ventilators, whether practice makes perfect. If you as an institution care for more people, do you have better outcomes? And we've seen this in other areas. Surgeons that do higher volumes of heart surgery actually have better outcomes. And what we found here was that over time, we've seen a shift that if you do almost any levels of mechanical ventilation, you have pretty similar outcomes after you adjust for patient case volume. But at the highest volume centers, the centers that took care of the most mechanically ventilated patients, what you started seeing was worse outcomes. And we posited the idea this could be a strain relationship, meaning in settings where you had too many patients for the given number of staff, that it actually had a negative impact on patient outcomes. And we've seen that actually in this paper from New England Journal back in 2011 that suggested when staffing of RNs below target levels, below ideal staffing levels, that was associated with increased patient mortality. In COVID itself, this study was published in the Annals of Internal Medicine, and they found that a really strong association between caseload and COVID-19 survival, meaning independent of the new therapies that came online, and I think I've talked about them before, the introduction of steroids to treat patients who are mechanically ventilated and some of the other treatments that have come out as well. Independent of that, during the time where there were more patients in the hospital, they had higher mortality. And that would really argue for the fact that these surges were associated with worse patient outcomes. So that leads to this question: in surgeries and crises, increasing nurse respiratory therapy or physician staffing ratios is not equivalent care and can constitute a crisis in and of itself, especially when this goes on for a prolonged period. I think one of the key things to recognize is that the association between staffing ratios and patient outcomes is really not static. on day one of the pandemic, I think everybody had a great deal of resiliency. And, I can speak for myself. I was actually excited to pitch into what was a global crisis. And that feeling really waned over time. Not that I don't want to go back to the ICU and continue to provide great care, but it took more and more of myself to show up every single day. And so if you were to draw a direct correlation between surges and patient outcomes, what you would also see is that the mediator, namely the individual healthcare provider, that changed over time. And so the longer we were in, whether you call it a contingency or crisis mode, the harder it was to justify that it was functionally equivalent care. So what we did in Colorado, at the very least, was adopt or draft crisis standards of care for healthcare staffing. And that was activated at two separate times. One was at the beginning of 2021, and then again at the end of 2021. It was deactivated in February, I believe, after Omicron started settling out. But the core principles around crisis standards of care for healthcare staffing were that it was intentionally vague. And that's really critical, as opposed to a strict scoring system for allocating ventilators or other scarce resources. This idea of healthcare staffing, it has to be adapted to local needs. We know that the staffing needs in one hospital may be greatly different than another hospital. And so you kind of have to draft it to be intentionally vague. It also recognizes this idea that healthcare is team-based, and loss of or damage to one group of staff members affects everyone else. I think the key points are that staff rather than stuff became the key crisis and shortage, and that staff are not infinitely flexible. They are finite resources like ventilators and hospital beds, because when you push them too far, when you stretch them too far, much like a rubber band, they snap. And what that manifests is either in worse patient care, as I've shown in previous slides, or they leave the field, and that's what we've seen a lot of. And that exacerbates the staffing. So what did the crisis standards of care for healthcare staffing really lead to? So it led to system modifications. And with regards to COVID, when there were issues, especially around PPE availability, some of the recommendations, and none of these are mandates, but there are recommendations, were to cohort patients with specific PPE needs to reduce total PPE usage, reduce or suspend non-urgent procedures, reduce or suspend outpatient medical appointments to be able to bring in outpatient providers into the inpatient setting where the crisis was actually being felt most acutely, but also to expand the use of telehealth to allow healthcare workers who may be required to quarantine or isolate to continue working if appropriate. So these, especially during Omicron, this was important because we had a lot of healthcare workers who were relatively asymptomatic, some of whom wanted to continue working because they recognized that when they were staying home for 10 days, it put an undue strain on their coworkers. And again, I think that's the team-based nature of healthcare, is that we all try and stand up, not just for our patients, but for our coworkers and colleagues. And it's actually one of the things that's kept me in healthcare, is this idea of the team-based approach as opposed to the solo practitioner. So these were all suggestions. Much of this was being done even independent of the declaration of crisis standards of care, but with these recommendations came actual additional legal protections. Some of the additional suggestions were to increase staffing ratios or create innovative staffing models such as team-based nursing. You may have a single ICU nurse who works with 2 or 3 nurses who would routinely be working on the floor, and collectively they may manage 6 to 8 patients. Bring in staff from other areas, so the outpatient to inpatient. Utilize temporary external staffing. I will talk about that directly later on, this idea of travel nurses, travel RTs, and locum physicians. Reduce staffing redundancies, and we've seen that in several areas. Uptrain or cross-train staff, so taking an LPN and expanding their role to maybe be a full nurse, or in some settings, students were given a little bit extra leeway in an inpatient setting under the supervision of a licensed practitioner. I don't think this happened in a lot of areas, but utilizing family non-medical personnel for non-medical tasks like oral hygiene, bathroom assistants, and just-in-time training for specific skills. Some of these may seem obvious, but I think some of the critical things that this did was provide legal protection for these issues. So especially, say, if you're asking a family member to watch a to help the patient to the bathroom, maybe a family member that doesn't have medical training, you can imagine if the patient falls, that might be legally actionable. And so part of crisis standards of care, especially say around increasing staffing ratios, it was adding or beefing up legal protections to providers and their licenses. There was also recommendations for administrative changes. So postpone licensure renewal, postpone non-urgent inspections or reduce non-urgent meetings, and reducing documentation burden. I think some hospitals utilize more crisis documentation protocols. So really reducing how much had to go into the chart. Obviously that you have to meet all the federal requirements as well. But I think this was designed to try and allow a smaller pool of healthcare providers to spend more time with patients. And again, these were all suggestions. Hospitals adopted them at varying rates during the declaration of crisis standards of care. But really, this was one of the first documents, I think, in the state that really highlighted that you can have a crisis in staffing, crisis by all previous definitions of it, crisis standards of care, and that it could affect staff, not necessarily just the stuff like ventilators. And in fact, some hospitals added this to patient charts and after visit summaries. This is some language from a specific hospital that just highlights that, you know, everything is operating under crisis standards of care for healthcare staffing. And that may affect the frequency with which we provide care, the frequency with documentation happens. And so this was in place for several months in the last year. And, you know, it's unclear how much it helped, but I think it gave a lot of people some sense of security in terms of the potential for legal action when people are working in under extraordinary settings. So how does this move forward now that we're out of crisis standards of care? Well, some of these core ideas can still be applied even during the ongoing staffing crunch. Maybe that's the better word to use since crisis now has a technical definition. I do want to discuss how staffing shortages can lead to downstream and upstream ethical conundrums. So we've talked a lot about how staffing is related to both the core issue of not having enough staff to manage an ICU bed. So you eliminate ICU beds from the pool, you eliminate ventilators from the pool, or you can perform fewer sessions of dialysis. So that direct triage. We've also talked about how just having a strained staff leads to worse patient outcomes, and I've presented a lot of evidence that would support that. So those are some of the core conundrums, but there's also upstream and downstream ethical conundrums. So in this graphic that I've created, I try and describe in a very simplistic way the ideal flow of healthcare. Ideally, you have outpatient care that then flows into an inpatient setting with an emergency department and inpatient care, both of which have excess capacity. Theoretically, you should have some degree of excess capacity in the outpatient care. I just didn't include that. And that once you leave inpatient care, you can go back to outpatient care, or you can end up in some sort of post-acute care setting, including home health. And again, there is before the pandemic, some of these operated with some degree of excess capacity. So how did this change when you started facing severe staffing strains? And how can that lead to some real ethical conundrums? So first off, I want to highlight that I've talked a lot about inpatient settings, but really where some of the staffing issues are the worst is in the post-acute care setting. And it's been really hard to find nursing homes or long-term acute care hospitals with adequate staff. And the home health agencies, the largest one in Denver, actually shut down 2 months ago. And what we've seen that it's significantly harder to get patients into these facilities due to staffing shortages. I've actually had times where I've been on the service where I was told that a certain facility wasn't taking any admissions or considering any admissions, not only because they didn't have enough staff, but because the admissions office all were out sick with COVID or some other issue. And so it really limited the outflow of inpatients to some of these post-acute care settings. And that would lead to the bottle filling up. And you had this increase in inpatient care that was driven heavily, not entirely, but heavily by an inability to send people out. You had decreased output. And what that would do is almost a reversal of flow. Not that you would have, where you have things that would typically be done in inpatient care, namely patients would be moved from the emergency department to an inpatient setting, a hospital bed, and you would see them waiting in the emergency department for a far longer period of time, receiving a lot of their care in the emergency department and not necessarily in the inpatient setting. And that has a lot of implications for patient safety, patient monitoring, patient care, and the actual quality of care that they get. We also know that it's harder for the emergency department to provide the excellent care for patients in extremis when they're also managing a host of other patients that should not be in the emergency department, but should be, potentially upstairs. So what did that lead to? Well, we then saw an increase in outflux of inpatient care. So patients that would typically stay in the hospital for a few extra days, maybe discharged earlier, maybe still more acutely ill than they otherwise would have been. And that puts an added strain on outpatient care. And I've talked to several primary care providers about how they saw an increase in acuity of their patients that had been evaluated either in the emergency department or were hospitalized for a certain number of days. And they would say, oh yeah, this patient would have typically been in the hospital for another couple of days, but now I'm seeing them on post-discharge day 1, and they have this slew of problems, and we don't necessarily have the resources to take care of it. And then you also started seeing patients being discharged earlier from the emergency department back to outpatient care without necessarily the full workup. You'd also saw more patients being referred from outpatient settings to the emergency department because they're strained in that setting as well. And so you can see that whereas typically people are thinking, in the studies that I presented have really focused on the red box of inpatient care, that the staffing shortages, both upstream and downstream, really affect the entire healthcare system and have a huge negative impact on patient care. What are those impacts? So let me lay out a few potential issues, and we've seen data around some of these. So when post-acute care facilities fill up, so that would be the nursing homes, the LTACs, the home health. When those post-acute cares fill up with home health, or when home health is unavailable, inpatient teams are unable to discharge their patients from the hospital. So they stay in the hospital. And in a setting where we're limited in the number of beds or limited in the number of staff members we have, how do we weigh patients who are acutely ill, so either in the emergency department or still sick in an inpatient setting? How do we weigh them against patients who probably have completed their acute medical treatment needs, but now lack a safe enough discharge plan? And that's really hard because if you discharge somebody not to a safe location, say somebody needs a nursing facility, but you force them to go home with no home health aid, in favor of accepting a patient from the emergency department to a bed, well, you can imagine the media headlines, but also now you're probably expanding worse outcomes to maybe 2 patients. Or when inpatient services fill up, there's backflow to the ED that can worsen patient outcomes. And we've talked about this. I mentioned that before. I think one thing where we are not anywhere close to understanding the full ramifications, and I think this is where some of the ongoing ethical challenges continue to exist, is that when we cancel non-emergent procedures to expand our inpatient ability to care for inpatients, are we actually creating worse long-term patient outcomes? And so there have been several studies that are starting to suggest that the suspension of routine colonoscopies, initially that was to preserve PPE, screening colonoscopies or other types of procedure-based screening may lead to an increase in late-stage cancer diagnoses. And that's going to lead to an increase in mortality in the coming 2 or 3 years. Same thing with people having missed mammograms or pap smears that may not have required a full-on procedure, but somebody visiting a radiological suite or getting a pap smear in their primary care clinic, if they couldn't get into their primary care physician or provider, then they may not have had that pap smear. And we've started also seeing this a little bit with lung cancer screening, that we're starting to see people who didn't get screening for a few years or 2 years, and they're coming in with nodules that are larger than we would otherwise think. For a while, we were really focusing on emergent procedures. So things like routine joint replacements were being delayed quite heavily because that's, for many people, they would view that as not being an emergency. But the patients that are in need of a joint replacement, whether it's a hip or a knee, may have severe pain, and this may lead to an increase in opiate use. And so one of the questions people have posed is there going to be an increase in opioid addiction because of delayed surgeries that are there for pain management and mobility issues, and then increase in the need for emergent coronary intervention. Somebody with who was in need of a bypass, but not in an emergent basis, may have been delayed for a few months or maybe longer in different states during the pandemic, and that's led to questions about whether or not some of those patients may have presented with an actual heart attack or myocardial infarction because they didn't receive the preventative surgery that they needed. And did that potentially lead to increased mortality? And we're seeing this as an ongoing issue. The backlog for procedures at institutions, at hospitals throughout Colorado and throughout the country, some are quoting numbers of hundreds to 1,000, while other institutions are quoting numbers in excess of 1,000 patients waiting for either a routine procedure, screening procedure, some type of surgery, like a joint replacement, hernia repair, things like that, and delaying surgeries because of that backlog or waiting to meet up with that, in combination to the first cartoon that I showed, which was demonstrating a shortage in OR staff, may really lead to worsened patient outcomes in the long term. And this is another way that staffing really meets some of those ethical challenges around patient care. I want to just put up a single slide about ethical challenges with travelers or just-in-time staffing. And just-in-time is also the name of a staffing company. I'm not referring to the company itself, but this idea of waiting until you need them and then hiring travelers. The concept of just-in-time staffing makes sense to deal with a short-term acute issue, but operating an entire healthcare system on that, I think we've shown in the last 2 years, really doesn't work. And what I think we have shown is the huge need for travelers suggested that we were operating on the smallest sliver of wiggle room in terms of staffing even beforehand. And again, we've looked at data about that. But what are the problems with travelers? I think in a lot of settings, travelers are amazing, right? They allow us to take care of more patients. They may have different experiences from different institutions, but some issues that have come up over time is this lack of site-specific experience, and whether in the setting of a crisis and prolonged utilization of travelers, does that lead to worse patient outcomes? The lack of a site or team investment. So if somebody's switching every 3 months, as I said, team-based medicine is something that I am very passionate about, and it's one of the things I love about ICU medicine. But if you have somebody that's only there for a short amount of time, maybe they're not going to have the same level of investment. And I'm not saying this about all travelers. I'm just raising issues that have been raised about the problem. Lack of team cohesion. I can speak to this. This large pay differential. So we know travelers are paid a lot more than people that have full-time status. They don't receive the same benefits, so the total pay may be more appreciable. But it's really hard to work next to somebody that's making 3 times as much as you when you're doing the same exact job, and that leads to worsened morale amongst full-time staff. The other thing is that, especially in the last 2 years, we've seen traveler companies, staffing companies, just jack up their rates, right? The demand is there, the supply is limited, and that supply-demand economics dictates price. And what's happened is healthcare systems are paying for travel contracts huge sums, and that inevitably is going to negatively impact the benefits for their full-time staff. And so we're seeing this push and pull, again, competing interests between the needs for patients. You need a certain number of nurses or a certain number of physicians or a certain number of respiratory therapists. The needs of the healthcare system, they need to staff to be able to take care of patients. But the finite amount of money that they then choose to provide to travel companies may negatively impact the staff. So what are potential solutions to hopefully I've been able to convince you that this was a problem beforehand and it's going to continue being a problem in the future. There's been some estimates that it's going to take us several years to improve our current staffing shortages. So what are some potential solutions? This is me coming up with some solutions, not data-driven, and not necessarily all of them being feasible. And I think this is going to take really extensive thinking by people much smarter than me at the system level, and not just like in terms of the staffing system level. How are we structuring healthcare? How does government interact with healthcare? How does government protect patients or protect staff? And so some of these ideas could be First I want to say that, the crisis standards of care for healthcare staffing, it's not a mandate, but allows for modifications for short periods of time. But crisis solutions are not long-term solutions. And as just allowing for increased staffing ratios within the realm of crisis standards for care may be okay for hospitals or healthcare systems, but obviously we've learned that that's going to fail staff and eventually fail patients. So some ideas have been around mandating staffing ratios, setting minimum safe staffing needs. And California has that as part of their, it's part of their hospital regulations. This has been something that has been debated heavily, I think, between different nursing organizations and hospital leadership. And then you have to think about the ethical issues of, in a short-term setting, if you do set a minimum safe staffing need, are you going to turn patients away when you exceed those staffing ratios for a few days or a week? How are you going to manage that? Because I know for a fact that most people want to take care of those extra patients. They don't want to turn people away. That's part of what we do in healthcare. But at what point do we recognize that taking care of more patients is actually negatively impacting all the outcomes for all the patients? Broader investment in staffing from leadership, I think that's really critical. And it's as crazy as it sounds. There's multiple reports in the media that major healthcare organizations have had record profits over the last year versus safety net hospitals like Denver Health and other places have not experienced the same. Expanding access pathways to healthcare careers. So this means educational pathways. There's been a big uptick in people entering nursing school. So they've had a big expansion in the number of seats, but there's a shortage in nurse faculty. There's a shortage in medical school spots, a shortage in residency spots. And respiratory therapy is another area where expanding access or thinking differently about how we actually, do we have two tiers of respiratory therapists, senior levels that spend, do the traditional training, and do we have people that can maybe go through a shorter level of education that could be extenders? Reducing administrative burdens. I can tell you the amount of time that I spend on renewing licenses, renewing DEAs, but also doing administrative stuff within the institution. That takes a lot of time. And so that affects our ability to spend time with patients. Team-based care approaches may be something, investment in staffing research. I think that I've shown you that there's bad outcomes for patients, but we haven't really seen a lot of research that compares different staffing models and what would actually lead to better outcomes. And that's a potential area of investment. We spend a lot of money as a nation on finding the next best drug or the next best chemotherapy, and potentially thinking about what's the next best care model may also improve patient outcomes and improve mortalities at a very significant level. And I think it's potentially an ethical obligation that we're facing now. And then potentially restructuring post-acute care staffing models as well. I think that's where we've seen the biggest pinch point. Thinking about how those places operate, they fall mostly under federal guidelines, but what's considered safe there, how do they actually staff their organizations, how do they pay for it? And we know that a lot of long-term care facilities and nursing homes are now for-profit institutions. So how do we manage that competing interest? And this goes back to the idea of managing competing interests. And I think this is where some of those core ethical issues arise, that hospitals, even nonprofit hospitals, want to have an operating budget that allows them to expand. And that's a good thing, actually. If they're going to expand services, expand facilities, expand faculty appointments, or invest in research, that's a good thing. They need that money. But at what point does that come at the cost of either patients or staff? Similarly, staff, turning patients away or triaging patients to not receive care because we don't have enough staff, that leads to bad patient outcomes. But is that possible in the short time? What's an acceptable degree of time to overburden staff? We don't know. And these are questions that are ongoing. What I want to say in conclusion is that we really cannot separate the ethical challenges of staffing shortages from the burnout, mental health, and moral injury so many of us are facing. And I really think that this is the trifecta. Burnout was something that used to be studied independently. Burnout is something separate from mental health. And moral injury was not something we talked about. Burnout, the definition talks about workplace burnout. it's impossible to separate that from the moral injury that a lot of us face, either by watching the news and seeing all the people that don't want to get vaccinated, the laws against people being vaccinated, the fights against masks, the school board meetings that talk about scientific policy without the scientific knowledge, on both ends. And I'm not taking a viewpoint on any sort of political issue here, but it's hard when you're taking care of COVID patients in your daily lives and you're seeing the impact of COVID on society, that moral injury bleeds into your workday. And now you start seeing how all of these issues are unifying. And I also think that another area that's going to affect staffing is PTSD. The PT, post-traumatic stress disorder, I think is really important to recognize. And as the COVID numbers have gotten better in the hospital, I think we're going to start seeing more mental health issues among some people. So what I really want to say in closing is thank you to everyone who has worked tirelessly for the last 2 years. I know it's really hard for me that while everyone else is moving on, all the people that I know not in healthcare, we're still in the thick of it in terms of working really hard in the hospital, although our COVID numbers are better. And then I live in fear of the next surge. So you're all superheroes to me. So thank you to everyone. I'm happy to take questions. And that's my email if anybody wants to send me a question via email. And I'm going to turn it back over to Julie.
Yes, and Anuj, thank you so much. We really appreciate that. Have a couple of comments and questions, a few of them in particular, starting with California and related to the staffing ratios. That California waived those ratios during the pandemic. Someone else mentioned California figured this out. It's time for other states to address mandatory staffing ratios. And there is a draft safe staffing bill circulating in Colorado currently. Could you speak to that?
Yes. Yes, California lifted their staffing limits during the pandemic as part of their emergency healthcare orders. And, you know, it's mandating staffing seems like an easy solution, but by default, that will reduce our ability to provide, to supply a certain degree of healthcare. Because if you say the maximum ratio for nurse to patients on the floor is 4-to-1, which I think is, you know, that's what some places have suggested, or 6-to-1 or whatever it is, that is far less than we currently are operating at. And so you can imagine that that's going to lead to shutting down a lot of hospital beds until we expand our staffing to meet that need. So it's a complicated solution. I fully support this idea of safe staffing ratios. For physicians, right, trainees have that protection. Residents and interns are only allowed to take take care of X number of patients before the hospital gets penalized. And I think we need to extend that to all care providers, nurses, respiratory therapists, and to figure out what is safe, but then also determine what's the wiggle room for short periods of time. Because I think we don't want to make something so rigid that it then negatively impacts patients more than it needs to. So I don't know the right answer. And I do know that there's a safe staffing bill being circulated. And I think the idea of potentially writing it in terms of crisis may actually be useful, saying, this is what we consider to be safe. This is what we consider to be the contingent staffing level that can only operate for X amount of weeks or months. And then this is a crisis staffing model, but in the setting of crisis, we also need a declaration of this to add on all the legal protections. So I think there are ways to really think about it from a complex, multidisciplinary 360 approach, but I definitely don't have all the solutions, or maybe any of them.
Well, it's a dynamic, isn't it? It's not just a static math problem. It's very much a dynamic. There are some references in the chat about staffing models and questions about executive salaries impacting both nurses and providers and so forth. I have a question related to staffing models. There's been such a rise in unionizing or potential unionizing. And do you see that as, particularly among nurses, do you see that as a direct consequence of these kinds of issues?
I think so. I think in Colorado, Longmont Hospital unionized their nurses. And some of the stories we heard from nurses there, I think were really heartbreaking in terms of the level of care they were able to provide. I think we're going to learn a lot in the next couple of weeks because there is I think two major systems in California, their nurses are going on strike for a predetermined amount of time. It's like for a 24-hour period, the nurses are going on strike in Northern California at two major systems. I can't speak to the exact systems for all of these issues. And I mean, that's the extreme of unionization is this idea of collective bargaining. And then that's part of the weapon that people have, but as a public service, it's really complicated. And I think that the public reaction to what happens there is going to dictate a lot of what happens elsewhere. But I think that there is an increasing push to unionize, and it's not just amongst nurses. I've seen that push amongst physicians as well, this idea of, and you know, I think in healthcare in general, we do a terrible job talking about money and talking about safe working conditions.
Thank you. I particularly appreciated your flow chart. The visual is very helpful and very, very true in terms of the description of what has happened over time. And one of the elements of that is how do I want to say this? There's so many different sociocultural issues in terms of, for instance, the discharges, and that often the people who are unable to be discharged because they cannot get into post-acute care settings are people either who are disadvantaged, marginalized, vulnerable, and must, and remain in the hospital for a year, 2 years, things like that. And wondered if while there are all of these really important competing moral obligations, how does culture enter into that model from your perspective?
That's a super tough question, but I think also really important. It's not just culture. I think that race and ethnicity, yes, primary language, all of our social determinants of health play a heavy role. And we know that that there are definitely post-acute care settings that are more willing to take private insurance than Medicaid or Denver Health Medicaid. If you have a tracheostomy, Denver Health Medicaid doesn't have a long-term acute care service, so you stay in the hospital. And that's your long-term acute care, which is definitely not as good as a dedicated weaning facility. So it definitely plays a role, and I'm going to expand that even further, is this idea of if you don't have access or you don't have the money to pay for post-acute care, whether it's home health aides or a spot in a nursing home for a loved one, and you have to take them home, we also know that some of our underrepresented minorities, while they have the multi-generational homes, and I think in some settings are more willing to take care of their loved ones, it impacts their ability to work even more. And those are the groups that have been actually negatively impacted by the pandemic in terms of job loss, wage loss. So now if they have an additional person they're caring for at home, it makes it even harder for them to be able to maintain regular employment. So that impacts their health insurance. And it's a slippery slope. I mean, I think it really affects everything across the board. I think how race, ethnicity, and those other social determinants of health impact or mediate these relationships has not been studied. And I think that we're in a crisis point. And one of the ways to leverage this moving forward, I think, is that we actually, in a year, will have a lot of data about how shortages impacted patient care and patient outcomes. And far too often we focus on how did diabetes impact this association? How did heart failure? And what I think another lens through which we can analyze this is how did social determinants of health impact the ability of or mediate the relationship of the staffing shortages.
Anuj, I thought there was a Colorado working group separate from the legislation being proposed that is working on it. Am I just mistaken about that?
Working group in terms of what?
Staffing.
There have been a few different working groups, so I'm sure the Colorado Nursing Association is probably has something, and I see Colleen's on the call. Colleen Casper from Colorado Nursing Association. I'm sure they have stuff that I don't even know about. All I can speak to is what I was involved with, which was the crisis standards of care for healthcare staffing. And then the state is also trying to put together some work around the moral distress that people are facing. And then obviously there is a push within Colorado to adopt state safe staffing legislation, but that's obviously very controversial. In the past, it's been heavily lobbied against by certain groups, especially large healthcare lobbies, despite the fact that it could potentially lead to improved patient care.
You answered, someone had asked, Maria Callas asked what home health agency closed, and that's 24/7 Home Health.
Yeah, that was
Okay.
Came out of the blue. I actually don't know most of home health agencies. I was trying to discharge somebody from actually the ICU, and in our social work rounds that popped up. They're like, oh yeah, we're having even more difficulty getting patients, because it's actually interesting. As the hospital filled up, actually, we were keeping patients in the ICU for longer periods of time, even though they were no longer critically ill, because I had no bed to send them. And that the availability of beds actually was dictated by staffing. And so we in the ICU were discharging people home, and whereas they have discharge coordinators on the floor, we didn't have any in the ICU because that's not typically what we do. And that's another dimension by which the short staffing, say on the inpatient settings, negatively impacted our ability to care for patients in the ICU setting, and then impacted our ability to discharge them. So it's, thinking about this, it's just the number of levels at which this permeates both our healthcare system and our society is staggering in my mind.
Right. It just brings to mind that it may be that there is some other creative way of some different jobs that in healthcare to help meet these needs that are not currently in place, that might provide, I mean, some of it are like scribes and things like that to help with the documentation, but shifting the load and also having other kinds of institutions for people to be able to go to out of an acute care hospital while they recuperate. But in any event, we have what we have for the moment. And I want to thank you very, very much for all your work on this, all your work the last couple of years for sure, but all your work on this. And it is with us and will be with us, but really appreciate it, Anuj. Thank you very much. All of you, we will, next month in May is our research month. So we will have a presentation on ethics in research, and watch for that flyer to come out. And we look forward to seeing all of you next month. Thank you very much. Bye-bye.